স্টার্ট হয়ে গেছে। স্টার্ট হচ্ছে। এখানে কি কোনো কমেন্টস দেখা যাবে? দেখতে পারবেন, মানে কেউ যদি অনলাইন আছে কিনা আছে দেখতে পারবেন। ট্যাবে যাওয়ার পরে গুগল ক্রোমে এটাতে। আচ্ছা, ফর্মটা কেউ এখনো আসে নাই মনে হয় না। কমেন্ট করে নাই, বাট চলে আসছে 6 জনের মতো চলে আসছে। Okay. Bismillahirrahmanirrahim. Ladies and gentlemen, Assalamu alaikum. My name is Dr. Tayyip. I work as a registrar in the Department of Medicine. And I hope you guys can hear me clearly. Today I'm going to talk about the X-ray of pleural effusion, and this class is for 21st batch only. I previously took a class on pleural effusion in the Zoom platform, but that day the connection was very poor and many of you couldn't listen to me and you complained about it. So I'm reading this class in Facebook Live. I never used Facebook Live before, and this is a total new thing for me, and there will be a learning curve. So if there's some problem, then bear with me and stay with me. It will be sorted out in later classes. So I hope you are all right. Everyone's all right and staying corona free. Those of you who attended the last class and could hear properly, you can skip this class. So let us proceed with it. একটু কি আসবেন, আমার পিকচারটা কি দেখা যাচ্ছে? আমি কিছু বুঝতেছি না। So hopefully you can see this picture. It's a picture of pleural effusion. You know, pleural effusion is such a common topic in the final MBBS examination. It's everywhere. We go to the board examination, there is an X-ray of pleural effusion. You go to the short cases, there will be a patient with pleural effusion. Sometimes in long cases as well, they give pleural effusion as a long case. So I hope you can remember the basics that we check when examining a X-ray. So in this chest X-ray, first of all, you should check the side of the X-ray, and even though there is no inscription such as R or L in this X-ray, but from the position of the fundic gas over there, we can tell that this side is left, and from the position of the cardiac apex, you can also determine which side is left and which side is right. And next, we check the uh, position of the patient, and you can see that the uh, thoracic 3 and thoracic 4 vertebra is equidistant from the medial end of the both clavicles. So the position of the patient is also all right here. And thirdly, we check the bony configuration, and we can see mostly it seems all right. There is no fracture or no extra rib or any rib notching. Number 4, we check the position of the trachea. The trachea is supposed to be central or slightly shifted to the right, and in this case, the trachea seems slightly shifted to the right, which is all right. It seems all right to me. Next, we check the position of the diaphragm, and the left diaphragm, even though it's all right, but the right diaphragm is not clearly seen because of a homogeneous opacity. When you check, when you see uh, white shadows in an X-ray, we call it opacity, and it indicates fluid or solid. And when we see blackness, increased blackness in an X-ray, we call it translucency, and that indicates air. So in this X-ray, we can see that there's increased whiteness involving the mid and lower zone of the right lung, and that opacity is homogeneous. It's equal everywhere. And the cardiophrenic and costophrenic angle, which we were looking for, we couldn't find it because it was obliterated by the uh, white shadow. And the position of the heart, it seems all right to me. It's not shifted. So if we are to describe this X-ray, we'll say that the chest, this is a chest X-ray posterior anterior view showing homogeneous opacity involving the mid and lower zone of the right lung with a crescentic upper border. And there is obliteration of the cardiophrenic and costophrenic angle. The position of the trachea is slightly shifted to the right, and the position of the heart is in normal position, and the bony thorax appears normal. So the diagnosis will be right-sided pleural effusion. So the next question that comes, why this is not consolidation? Now this is not consolidation because in consolidation there's supposed to be presence of air bronchogram. And this X-ray does not have, this opacity does not have any air bronchogram within it. It is devoid of any air bronchogram. It's a dense homogeneous opacity. So this is not consolidation. Why this is not collapse? In collapse of this scale, the trachea and heart should be shifted towards the side of the lesion. We'll show it in a separate X-ray later. And pleural fluid is, because it's fluid, it is tend to be found in gravity dependent position. In case of collapse, it doesn't. So if this is pleural effusion, how much fluid is in there? কতটুকু পানি আছে এখানে? বলা হয় যে for pleural effusion to be detected clinically, there has to be 500 milliliter of fluid present in the pleural space, whereas normally there is only 3 to 5 ml of fluid. So at least 500 ml of fluid should be present in the pleural space to be detected clinically. And for X-ray in posterior anterior view, there has to be 300 milliliter of fluid present. And in X-ray in lateral decubitus view, there should be 100 milliliter of fluid present to be detected by the X-ray. And ultrasonogram is much more sensitive to detect fluid, and ultrasonogram can detect up to 20 to 25 milliliter of fluid uh, if it is present in the pleural space. So the next question will be, what will be the clinical findings if you were to examine the patient in the bedside? If you were to examine the patient in bedside, the clinical findings, usually we describe it in 4 categories: inspection, palpation, percussion, and auscultation. And in a patient with pleural effusion, this patient, there will be restricted chest movement on the right side in inspection. In palpation, we see 4 things. First of all, the position of the trachea. It is supposed to be central in this case, but if it was a massive effusion, then the trachea would shift to the opposite side. And the position of the heart in this X-ray, and in this patient, the position of the heart will be in normal position. Means the position of the apex beat will be in the normal position. Chest expansibility will be reduced on the right side, and vocal fremitus will be reduced on the right side. If we are to percuss over this effusion, then we'll find there is stony dullness. And stony dullness is a hallmark, clinical hallmark for pleural effusion. If we were to auscultate, when auscultating the chest, we see 3 things: the breath sound, any added sound, and vocal resonance. If we were to auscultate over this effusion, then we'll find that there is diminished vesicular or absence of breath sound over the effusion, and there will be no added sound, and the vocal resonance will be diminished. But it is said that on top of the pleural effusion, there is collapsed lung, and on that part, on top of the effusion, if you were to auscultate on that part, there will be bronchial breath sound because of the collapse of the lung, and vocal resonance will be increased over that part, and vocal fremitus will also increase over that part. Only over the top of the, on the top of the effusion, but not over the effusion. So there's clinical findings. Next question, they may ask, what is the cause? What may be the cause in this X-ray? Before shifting to cause, let me show you some more pictures of pleural effusion. Then we can talk about the causes and investigations and other things. Please hold on. The first picture that we showed you, it was a picture of unilateral pleural effusion, but this is an X-ray of bilateral pleural effusion. The findings are the same, but it's bilateral. In the third picture, this is a X-ray of massive pleural effusion. You can see that the whole of the hemithorax is covered by the homogeneous opacity on the left side. This type of X-ray is often confused with whole lung collapse of the left side, but you should keep in mind that if it is due to collapse, then the trachea will be shifted to the same side, but in pleural effusion, it will shift to the opposite side. Here, the position of the trachea is not that much shifted, but the heart is definitely shifted to the opposite side. Oh, it's the same X-ray. And this is a more clear picture of massive pleural effusion with shifting of the whole mediastinum, including the trachea and the heart. So these are the X-rays that you may be shown in the radiological examination in the board. Okay, so let's shift to the causes of pleural effusion. Before discussing the cause, let us talk about exudate and transudate. You know, there are two types of fluid that can accumulate in the pleural space. One is transudative fluid. Transudative fluid has a protein content of less than 3 gram per deciliter and LDH content of less than 200 units per liter. And it is usually caused by increased hydrostatic pressure or decreased colloidosmotic pressure, as in heart failure, in nephrotic syndrome, in liver cirrhosis, hypothyroidism, protein-losing enteropathies, malabsorption, malnutrition, anywhere if there is increased hydrostatic pressure or decreased colloidosmotic pressure. In contrast, exudative fluid, it is mainly created due to inflammation. In inflammation, there will be increased capillary permeability, and there will be fluid loss in the interstitial space. And along with that fluid, there will be increased protein content in the fluid because of the capillary wall becomes more permeable to proteins. So in exudative fluid, the protein content will be more than 3 gram per deciliter, and the LDH content will also be more than 200 units per liter. And examples of exudative effusion includes tuberculosis, pneumonia, malignancy, pulmonary infarction, pericarditis, pancreatitis. Anywhere there is inflammation, it can cause anything that can give rise to inflammation can give rise to exudative pleural effusion. So, if the pleural effusion is unilateral, then the cause is usually the causes of exudative effusion. So, in an unilateral, right-sided pleural effusion, if the cause is asked, we'll first say that the cause may be pneumonia, parapneumonic effusion. Secondly, pulmonary tuberculosis, bronchial carcinoma, pulmonary infarction. These are the 4 main causes of unilateral pleural effusion. Let me repeat it again. Parapneumonic effusion, pulmonary tuberculosis, bronchial carcinoma, and pulmonary infarction. Now, if the effusion is mainly right-sided, we can add 2 more things to the mix. After the 4 that we mentioned, number 5, mention liver abscess. And number 6, mention Meigs syndrome. Meigs syndrome is a condition where there is ovarian fibroma associated with ascites and right-sided pleural effusion. So the causes of right-sided pleural effusion, unilateral, Pneumonic effusion, tuberculosis, carcinoma, infarction, liver abscess, and Meigs syndrome. If it is left-sided unilateral pleural effusion, we'll say that the causes are the main four, that is pneumonia, tuberculosis, carcinoma, infarction, followed by pancreatitis. Number 5 will be pancreatitis. Number 6, pericarditis. Number 7, dissecting aneurysm. Number 8, esophageal rupture, that is called Boerhaave syndrome. So if the effusion is left-sided, we mention the 4 causes first, followed by some special conditions that is present only in left-sided effusion. And let me mention it again, that pancreatitis, pericarditis, esophageal rupture, and dissecting aneurysm. If the effusion is bilateral, so far we're discussing about unilateral effusion. If the effusion is bilateral, then we will mention a different set of causes. In bilateral effusion, the causes are mainly transudative. Transudative fluids, as we mentioned before, are found in congestive cardiac failure, in nephrotic syndrome, in cirrhosis of the liver, in malnutrition, in protein-losing enteropathies, malabsorption, hypothyroidism. These are the conditions that give rise to bilateral effusion. But sometimes, if the pneumonia is extensive and present bilaterally, that will also give rise to bilateral effusion. If the tuberculosis or carcinoma that we mentioned in unilateral effusion, these are extensive and present bilaterally, that can give rise to bilateral effusion as well. So that's the causes. Please check it in the books. I know it's confusing. There are so many causes. So please check it in the book, the causes. Then you'll get a more clear picture. Then let's talk about the investigations that we want to do. In an unilateral effusion like this, what investigation do we want to do? The first investigation is obviously complete blood count. In complete blood count, we'll check the total count of WBC, if there is any leukocytosis, if it is neutrophilic leukocytosis or lymphocytic leukocytosis. And we'll check the ESR. And you know, the ESR will be raised in exudative effusion, and there will be neutrophilic leukocytosis in case of pneumonia. There will be lymphocytic leukocytosis in case of tuberculosis or malignancy. Then we check for sputum, because tuberculosis is one of the main concern, and also pneumonia. In sputum, we check it for Gram stain, AFP stain, and culture. Third examination may be Montauk's test or tuberculin test. The fourth test will be pleural fluid aspiration. Now we aspirate pleural fluid, introducing a needle in the space, and we check it in 4 categories. We check it physically, we check it biochemically to see glucose, protein, and LDH content. We check the cytological content of the fluid, cytological examination, and microbiological examinations. In physical examination, as we mentioned, the fluid may be clear or cloudy, or it may be amber colored in tuberculosis. cloudy in case of empyema and pneumonia sometimes. It may be reddish if there is infection or malignancy. And biochemical content is mainly seen to determine if it is exudative or transudative. We are checking it for glucose, protein, and LDH. We mentioned this before. Then cytological content. If there is more RBCs in the fluid, we are considering malignancy or infection. If there is malignant cells seen, then definitely it is malignancy. If there is increased neutrophilic content, we are considering pneumonia. If there is increased lymphocyte, then consider about tuberculosis and also malignancy. And then we do microbiological examinations. Microbiological examinations includes, again, checking the fluid for gram stain, AFP stain, and culture. And sometimes we do special tests like ADA, adenosine deaminase, and it is increased in case of pulmonary tuberculosis. And sometimes we check, we do other tests like PCR. We can do remote RA test, ANA, depending on what we are considering. We can check serum amylase. These are special tests that we sometimes do. But the four main tests that we do is physical, biochemical, cytological, and microbiological examinations. Okay. So it is often asked in the examination, what are the characteristics of tubercular diffusion? If the fluid is tubercular, in physical examination it will be amber colored. In biochemical examination, we'll find that the fluid is exudate. That is, the protein content will be more than 3 gram per deciliter, and LDH content will be more than 200 unit per liter. We'll find lymphocytic lymphocyte predominance in the fluid. And while checking the fluid for microbiological examination, we won't find anything in gram stain, and in up to 20% of the cases, AFP will be found, and in up to 35% of the cases, there will be presence of AFP in culture, mycobacterial culture. So it is not giving much yield. In such cases, we often do pleural biopsy. So going back to the investigations, what are the causes, what are the investigations that we'll do in such cases? We'll do complete blood count. We'll check the sputum. We'll do tuberculin test. We'll check pleural fluid aspiration and study. And what is the most confirmatory test? We'll do pleural biopsy. Pleural biopsy is much more sensitive than pleural fluid analysis for diagnosis of tuberculosis and malignancy. Where in tuberculosis there is only 20% positivity of AFP in fluid and 35% positivity of mycobacterial culture in the fluid. Pleural biopsy gives 80% positivity rate when we are drawing it, when we are taking biopsy from the pleura. And in case of malignancy, the yield is 40%. If you are doing pleural biopsy, you can detect malignancy in 40% of the case, which will be much lesser if you are studying the fluid itself only. So going back to tuberculosis, we mentioned the characteristics of tubercular fluid. how will you treat this effusion if this was tubercular? How will you treat tubercular effusion? We'll give standard anti-tubercular chemotherapy, that is 4 drugs, rifampicin, isoniazid, pyrazinamide, and ethambutol, and we give it in 2 phases, the intensive phase and continuation phase. In the intensive phase, we use 4 drugs, all 4 drugs, and in continuation phase, we use only rifampicin and isoniazid. In addition to standard anti-tubercular therapy, we use steroid as prednisolone 20 to 40 milligram daily for 4 to 6 weeks. It is said that if we use steroid in tubercular effusion, it hastens the recovery of fluid, and it prevents reaccumulation of fluid, and it also prevents development of pleural thickening. So we oftentimes use steroid along with standard anti-tubercular therapy. Now, how will we know if the fluid is malignant? You know, in a malignant effusion, there will be certain clinical characteristics. The patient will be older aged, the patient will be emaciated, there will be presence of nicotine stain, because mostly patients suffering from malignancies are smokers. There will be clubbing, and there may be presence of lymph node uh, uh, in the uh, in the neck and in supraclavicular spaces. In the fluid, it may be reddish due to increased RBCs. In biochemical examination, there will be exudative fluid. In cytological examination, there may be presence of RBCs and malignant cells. And in pleural biopsy, we may detect there is presence of malignancy. And we treat malignant effusion by treating the malignancy itself, be it surgery or radiotherapy or chemotherapy. There is a tendency of malignant fluid to reaccumulate, to be reaccumulated. So if there is reaccumulation, repeated reaccumulation of pleural fluid in malignant effusion, we often do pleuredesis. Pleuredesis is a procedure. It's a procedure that we do often in the ward to prevent reaccumulation. We inject inflammation generating drugs like bleomycin, tetracycline, talc into the pleural space. We inject bleomycin in the pleural space, and that bleomycin will cause intense inflammation of the parietal and visceral pleura, and due to that inflammation, there will be apposition of the both pleuras, and the pleural sac will be obliterated. And if there is obliteration of the pleural space and now there is no pleural space, there will be no reaccumulation of the fluid. That is the idea, to prevent patient's distress, to prevent recurrent reaccumulation. We do pleuredesis and obliterate pleural space in malignant pleural effusion. So I think it's I know it's a long class. It's been almost 1 hour, I guess. We discussed many things in the class. We discussed about the radiological findings, discussed about the clinical characteristics of effusion, talked about the causes, talked about the investigations and management. I guess this should be it. You have more classes now. It's almost 10 o'clock. So this is all right. Let's conclude the class here. Good luck, and thank you very much for staying.